So today I'm going to be talking on advanced surface ablation. So we'll all know that PRK or advanced surface ablation was the procedure of choice in the 1990 up to 2000. But of lately, we have seen that PRK has gone out of vogue. So what are the reasons that why PRK has gone out of vogue was mainly because the haze which developed post the PRK and patients who complained of pain post the PRK procedure. So what are the causes of haze that we found post PRK? We have a lot of published literature which showed that ocular inflammation leads to altered wound healing, and also that high UV radiation post the procedure causes late onset of haze. So how do we overcome these pitfalls of PRK? Now, we in our practice, what we follow are different rituals to prevent haze. What are the different preoperative rituals? One is to treat any kind of ocular inflammation, be it meibomian gland disease. So you treat it well with by giving the patient azithromycin, a copious amount of lubrications, hot fermentation, and in severe cases, you may even want to do something like a EI or a LipiFlow and treat the MGD prior to the procedure. Treatment of dry eyes and ocular surface inflammation is again very important prior to undergoing this procedure. Always check for contact lens intolerance, because if the patient has been contact lens intolerance, these patients usually do not do well with PRK. We always check if the patient has any keloids or if the patient is on any kind of acne treatment, because again, these are the patients who are going to develop haze post the PRK procedure. Then finally, also checking for vitamin D deficiencies. If the patient has vitamin D deficiencies, it's very important to treat it first, either in mild cases, either oral by vitamin D supplements, or in severe cases by even injectable vitamin D. Now, what do we do intraoperatively? Now, as we know, the epithelium which is removed in PRK can either be done by using alcohol, it can be done mechanically either by using a hockey stick, a spatula, or an Amoyle's brush, or you can do a laser removal of the epithelium. Now, in our study, which we conducted at our center, we found that the haze on the third day post the procedure was most in patients with alcohol removal than compared to mechanical removal, than compared to the laser removal. So patients who had undergone laser removal had the least amount of haze on third day post-op. Now, what are the in intraoperatively? Therefore, once the best method of taking out the epithelium with a laser prevents haze. And as we know, there are different modalities. You have the trans PRK, which can be done by the Schwind machine, the trans PRK, which is done by the Streamlight also. Now, in this, the advantage of the Schwind over the Streamlight is that the actual zone of epithelium removal in the Schwind can be adjusted to as minimal as 6 to 6.5 millimeters, whereas a Streamlight usually takes out the epithelium at around 8.5 millimeters. So it takes longer for the epithelium to regenerate. Therefore, patients do have pain for a few days post-operatively when patient undergo a Streamlight. Now, intraoperatively, it is very important to use the use of mitomycin C. We use mitomycin C 0.02%. Per diopter being treated, we keep the mitomycin C sponge for around about 10 seconds per diopter. Usually up to 6 diopters is the upper limit for the treatment of PRK. So maximum 60 seconds is what we keep these Merocel sponges for. Post-operatively, what we do is definitely steroid eye drops for 1 month post-operative patients. As steroids cannot be continued for long periods of time, we continue cyclosporins for up to almost 3 months. Supplementing the patient with vitamin D, as I had already spoken about. And also very important is UV protective glasses, as UV radiation is known to be one of the causes of late onset haze. Another thing is to use balanced salt solution for the prevention of pain post PRK, both before the ablation and after ablation. It is very important to use chilled balanced salt solution, as this is known and published to decrease the incidence of pain. A study which we conducted at my alma mater, Narayan Nethralaya, was where we used AccuVale soaked BCLs, that is ketorolac soaked BCLs. What we did is that the BCL was injected with AccuVale. It was kept for 20 minutes so it got properly soaked, and then placed over the eye following the PRK procedure. Now, what we found in a study done at our center again was that the laser removal, in that the epithelial healing was much faster than mechanical and even faster than alcohol removal, because the epithelium is removed in a more organized manner, and hence epithelial healing goes on faster as compared to the other procedures. We saw that hence these patients, by using the laser, had faster wound healing, faster epithelium healing, and hence had lesser pain as compared to mechanical or alcohol removal post the procedure. Now, what are the advantages of a surface ablation over LASIK or SMILE is that the main reason why we would do a PRK is because we all know is that PRK is a stronger biomechanical procedure as compared to the other two procedures. And the reason for this is that in a PRK, the anterior corneal nerves are not traversed, which happen in both the LASIK or in the SMILE procedure. So therefore, PRK is extremely beneficial, especially in patients who have a suspicious topography, that is a very steep cornea, a thin cornea, with patients with low pachymetry. If you have a pentacam and a bad D map, patients who are showing a poor bad D or a suspicious bad D, these are the patients who you should do a PRK than a LASIK or a SMILE. Again, in a patient of an irregular epithelium, if any patients have an epithelial hypertrophy, PRK would be the procedure of choice. This is because in LASIK or in SMILE, the epithelium is untouched. Your cap or your flap is at a much deeper level. So the patient is always going to have a poor quality of vision because of the aberrations which are induced by the hypertrophied epithelium. As compared to in PRK, in which you're debriding the epithelium off. So it would be preferable that if the patient has an epithelium of almost 60 to 64 and it is irregular in different places, you can do a manual removal of the epithelium. And if the patient has a regularized epithelial hypertrophy, then you could do it with a laser. We also is well known that because the PRK is a biomechanically stronger procedure, when you do a search, you even find that the incidence of ectasia is the least in PRK as compared to LASIK or a SMILE. Now, also, as we've already discussed in this talk earlier, people who have professional requirements, people who are in the army, navy, where they do not need a scar to be seen, prefer to undergo a surface procedure than a LASIK or a SMILE. And people who are playing contact sports, football, rugby, any kind of procedure where the flap could be displaced would do well with the PRK. So I'll just run through a few examples of procedures where we could do a PRK instead of doing a LASIK or a SMILE. So here we had a patient who was a 29-year-old patient. Here we see with a refractive error of around about 2.75. Patient had a borderline pachy of around about 503 as the thinnest corneal thickness, and also had a steep cornea of around about 46 diopters, and also a suspicious bad D. So such a patient would do well with the PRK. You can go ahead and do a PRK instead of taking a risk with going ahead with a LASIK or a SMILE in this patient. Again, a second scenario here, a borderline pachy, again of 501 thinnest corneal thickness, but I had a posterior elevation again in the suspicious range of 16 microns. So again here, the reason for which was a poor bad D again, and such a patient again, you can consider doing a PRK in this patient. And finally, any patient who has a thin cornea, a cornea of thickness of just around about 490, would again, you can consider doing a refractive error of only around about -3 diopters would do well with the PRK. Thank you.